Hello, everyone. My name is Min Suk Soo, and today, we have prepared two sessions regarding thyroid cancer, and I believe there are actually more experts and more experienced nuclear medicine physicians in here than me. And I have very short experience of thyroid cancer treatment. So today I will briefly summarize and review the current guideline for thyroid cancer treatment. And next time, I think our colleagues from other Indonesia and Vietnam and maybe Bangladesh can share their expertise and their experience regarding the thyroid cancer treatment status in each country. So, and next week, Professor Edmund Eugene Kim will organize the session. So, okay, I will start today's. So if you, I think you might have many expertise in the field for thyroid cancer treatment. So if you have any questions or comments in between the lectures, so please freely, you can just speak out using, or you can also write down at the chat so we can discuss. So today current guideline for thyroid cancer treatment is largely, I have prepared largely based on the, actually not, it is not like current, it was ATA guideline was made in 2016. And our, the Korean Thyroid Association guideline, and I have referred also to the NCCN guidelines. So these are mostly referring to those three guidelines. Okay. Okay, first, I'd just like to have a quick questions, and I think everyone can participate. So what do you think? And actually it is not, we don't know who's answering, so you can freely answer to the questions maybe. Okay, so 45-year-old male patient had a palpable thyroid nodule, and in the history taking, they had no previous history. And from the physical exam, we could have seen 2 centimeter size palpable nodule in the right lobe. And the TFT result was that TSH level was 0.03, which, so, okay. So mostly, I think most people are well recognized, well known for the current guidelines. So as you can see, we can like think about sonography and technetium thyroid scans. So let's see the guideline. So actually from the guideline, when we see a thyroid nodule, it's not only for the Korean Thyroid Association, but it's also from ATA guideline that if we can see a palpable nodule, first thing we have to do is like history taking about whether the patient had a history of radiation in the head and neck area, and like other family history of thyroid cancers. And also the first thing is to check the serum TSH level. And if the serum TSH level is low, the first thing actually can be done is to do the thyroid scan. And actually it is to find out whether the nodule is a hot nodule or a not hot nodule. So for the hot nodule, actually mostly it is due to a autonomous nodal or nodular goiter or functioning adenoma, which is a benign. So we can easily rule out without a thyroid sonography that this is a benign nodule. However, if it's not, if the TSH level is normal or elevated, and if thyroid scan has a not hot nodule, we can refer to a thyroid sonography. And after that, we can go on, according to the imaging findings, we can refer to a FNA or a regular follow-up. So we will see what happens next. And actually for this patient, we think as the TSH level is low, the first thing to be recommended is to do the thyroid scan. However, in the real, practically, currently, recently, most of people are coming to the hospital because they have found a nodule in the healthcare center, not by a physical exam. And also other CTs or FDG PET incidentaloma can be found and come. So actually, we have seen more of FDG PET thyroid incidentaloma rather than a thyroid scan for the differential diagnosis of the thyroid nodule. But still, we might need to remember that when there is a palpable nodule, and the TSH level is low, the first thing to recommend is the thyroid scan, and we can differentiate and to find out whether it is a hot or warm nodule. And so if it's not, we can move on to the thyroid sonography. And for a standardized reporting, the Korean Society of Radiology and Thyroid Association has reported a Korean thyroid imaging reporting K-thyroid system. And actually, it is not only, there are thyroids for which can be used, and we have somewhat modified about the risk for the nodular size threshold to actually minimize the FNA and the attempt of FNA, but not to reduce the sensitivity for diagnosing the malignancy. So some of the size threshold for biopsy has been revised in the current guideline, and I think most of may have their own or may follow the thyroids. And so according to these reporting system, you can see that according to the US, the ultrasonography patterns, the findings can be categorized to 5 categories, like no nodule, benign, low suspicion, intermediate, and high suspicion. And what we do is, why we categorize these systems is where we should recommend the biopsy, the FNA. So according to it, if the thyroid have a low suspicion of pattern, but the nodule size is bigger than 2 centimeters, then we can go on for the FNA to confirm the pathology of the nodule. However, if it is 1.5 centimeter and have a low suspicion, we can wait and have a regular follow-up. Okay, so then we next move on to the biopsy results. So we do the FNA and we get the result. However, usually the pathologists think their report, we also understand samely as they're thinking. However, in the past, there was some discrepancy in the understanding of the clinician and the pathologist. So there has been a system made thyroid, this Bethesda system, which is which the purpose is to give a standardized recommendation and standardized reporting form of thyroid cytopathology. And it is also categorized to this here, like non-diagnostic, benign, atypia, or follicular neoplasm, or suspicious malignancy, and malignant. And actually, this category is based on the probability of the risk of malignancy. And just one thing, and why we categorize this is actually to recommend what is the next management for this patient. And as you can see, there is one NIFTP, and it is like the risk of malignancy is differed whether this NIFTP is thinks as a malignancy or not. So this NIFTP, just for addition, is a non-invasive follicular thyroid neoplasm with papillary like nuclear features, and just recently achieved it is a recent definition of some PTC, a very small portion of PTC. And in worldwide, it is known like 9% of all PTC there is this NIFTP. And in Asian, the ratio seems to be lower to like 2%. And so PTC can be have a follicular variant type, and it can be also the follicular variant PTC can be also divided into encapsulated, however, or infiltrative, and this encapsulated can be also divided into invasive and non-invasive. And this non-invasive is recalled as a NIFTP. And because from the follow-up studies, these patients have very good prognosis and very low probability of malignant transpiration or recurrence or other infiltration. So recently, these NIFTP is regarded as non-cancerous region, but still needs a follow-up. Okay, so according to this Bethesda system, we can define when it recalls as a benign, and then what we should do is we should, according to the sonography finding, we can have a different decisions. So the FNA result is benign, but the sonography finding has a high suspicion. We can repeat the sonography within like 12 months. However, if it is intermediate suspicion, we can sono follow-up can be prolonged to 12 to 24 months. And if there is a size growth and a new lesion, we can again do a FNA. And actually, this repeat means a repeated FNA. And if there is a low suspicion from the sonography finding, we can repeat like more than 2 years later, and 2 years later, and FNA can be considered as samely as an intermediate suspicion. And if from the repeated FNA there is no, it is negative, actually no more follow-up is recommended for these patients. And for the non-diagnostic case, but the first thing should be done is repeating FNA by sono-guided FNA. And if it again comes like non-diagnostic cystic nodule, we can consider surgery if there is a high suspicion of malignancy in sonography, and if there is a high more than 20% of tumor growth, and if the patient have a clinically high risk, like a family history or like radiation history from the head and neck. And otherwise, we can just do a active follow-up for these non-diagnostic cases. And for the atypia of undetermined significance and follicular region of undetermined significance, the first thing is to repeat the FNA and to review again about the clinical and sonography findings. And it might be similar to the flow of what have been done in the non-diagnostic cases. However, recently incorporated importance is to incorporate the information from the molecular diagnostics. So if we incorporate like 7-gene panel or gene expression classifiers, we can enhance the sensitivities to be higher. Like sensitivity can be enhanced to 90% if we do a gene expression classifier. And so in those cases, lobectomy can be performed unless this molecular profile is benign. And for the follicular neoplasm or suspicious of follicular neoplasm, actually the same principle can be applied compared to the AUS and FLUS. Also importance is to incorporate the molecular findings like 7-gene panel and Thyroid, which is using the mRNA. And using this Thyroid as a next generation sequencing technique can enhance the sensitivity and specificity very high. Okay, now like for the malignancy and suspicious of malignancy, generally surgical resection is recommended. However, recent studies have argued that active surveillance can be considered in patients with like very low risk, and like if there is a high risk of surgery due to underlying disease or low life expectancy. And so in these cases, active surveillance can be considered in some. And in some case, pre-surgical evaluation of, and if there is a suspicion of malignancy and is planning for the surgery, evaluation of lymph node should be done. And since there has the prevalence of the lymph node metastasis in thyroid cancer is reported to be quite high, as 20 to 50%. And microscopic lymph node metastasis also has been reported to have a high prevalence. However, the clinical significance regarding the disease-specific modality of this lymph node evaluation pre-surgically is actually not known, and the significance of this regional lymph node metastasis is not known for this disease-specific mortality. However, if there is, according to the sonography findings, we can do the FNA if suspicious and like have a size of 3 to 5 millimeter, and if intermediate, and if the size is more than 5 millimeter, we can consider for the FNA to see the cytology. Okay, now we have done a pre-operative workup. So using the Bethesda system and the pre-surgical evaluation of the lymph node. So if the surgery is recommended, we can now consider whether to do for the total thyroidectomy or whether the lobectomy is sufficient for the patient. Before considering about why we should consider this is that from the comparative analysis and like other prospective studies and the meta-analysis also have consistently reported that when doing a total thyroidectomy, there has a more chance of adverse events compared to the thyroid lobectomy. And the adverse events were related with hypocalcemia or recurrent laryngeal nerve paralysis. So although the therapeutic effect itself, it's not different and there was a difference in the adverse event in a low risk, a very low stage patient. So these, what to be considered should be decided, and to decide whether this patient can consider total thyroidectomy or lobectomy is based on the clinical history and clinical findings. So if any of it present, usually the total thyroidectomy is preferred and recommended if we can see a no distant metastasis, absolutely. And like if there are extrathyroid extension and tumor more than 4 centimeters in diameter, and like other can be, and if there is any of these findings, we should prefer total thyroidectomy. However, if all these criteria are present, lobectomy can also be considered. Like if there is no prior radiation exposure, no distant metastasis, and no lateral cervical lymph node, and no external thyroid extension, and tumor with 1 to 4 centimeters in diameter, then lobectomy can be considered in these patients which matches all these criteria. And moreover, if the patient have a tumor less than 1 centimeters and no concerning lymph nodes, and so in this case, like lobectomy can be considered. However, like recent papers also have argued that active surveillance can also be possible in this particular patients. But in those patients, still, the total thyroidectomy should be considered if there is a clinically evident thyroid cancer in the contralateral lobe, or previous history of head and neck radiation, or strong family history of thyroid cancers. Okay, and regarding the neck dissection, like if there is a clinically involved lymph node metastasis, you should go on for the central neck dissection. But however, for the follicular thyroid cancer, it usually have less lymphatic invasion and lymphatic spreading. But follicular thyroid cancer have more chance of hematologic metastasis. So like prophylactic central neck dissection is not usually recommended for the follicular thyroid cancers. But whether the prophylactic without knowing the clinical involvement of lymph node metastasis, whether the prophylactic central neck dissection is needed is actually controversial. But however, because there is a conflicting data whether it can actually enhance the survival outcome or not. But mostly it says that there are like not that much difference, because these patients actually without the central neck dissection because of if there is no clinical evidence of lymph node metastasis, the patient, although they have a lymph node metastasis, may have very microscopic and very low number of metastasis, which can be actually cured by the ablation of radioiodine therapy. So there is a controversial, but still, it can be for the prophylactic central neck dissection can be considered in like young patients, and the patient which has a big or multiple tumor or locally advanced, which have more than T stage of 3. And if there is a clinically involvement of lateral lymph node, you can do the prophylactic central neck dissection. And like if there is a extrathyroid extension, you can go on. And like if this is needed for the after the surgery for the radiation therapy, radioiodine therapy, or for the follow-up of patient, if the clinician think it is necessary, we can go on for the prophylactic central neck dissections. Now, after the surgery, we can stratify the patient risk according to the findings. But before, usually the stratifying the survival, and this TNM staging is actually is relevant to the survival of the patient. And as you can see, the importance in the TNM staging of the thyroid cancer is it is differentiated according to the age at diagnosis. So this might be an important thing, and you can see that the age of the diagnosis have changed from the age of AJCC. And if it is less than 55 years, the importance is about whether there is a distant metastasis or not. And if for the older patient, the most important factors is that whether there is a extrathyroidal extension, and the actual extent of the tumor is a important factor. And this TNM staging is actually more relevant to the survival of the patient, not a risk of immediate recurrence or the response of the response. So to select a strategy to guide the management after the surgery is more relevant with this post-surgical risk stratification. And so from the ATA guideline, it is the ATA guidelines have given how to stratify the risk of the patient after the surgery. And they have categorized into 3 for low risk, and intermediate risk, and a high risk. So according to their risk, what they do next is actually defined. And firstly, we need to know what is the low risk. So low risk in the ATA guideline is a papillary thyroid cancer with all of the, so it should fulfill all of these criteria, like no local or distant metastasis, and all macroscopic tumor has been resected, and there should be no histology of aggressive histology like tall cell, columnar cell, or hustle cell, or follicular thyroid cancer, or Hopnell variant, and no vascular invasion, and other things should be all these things should be fulfilled to define as a low risk. And also, it should have a intrathyroidal encapsulated follicular variant, and like well-differentiated follicular thyroid cancer with capsular invasion and no or minimal vascular invasions. And also intrathyroid papillary microcarcinoma, including the BRAF mutation, can be also regarded as a low risk. And the intermediate risk can be defined if any of the following is present. And I think you might well know, and it is, so these criteria should be fulfilled. And for the high risk, and if there is a macroscopic tumor invasion, and like if the tumor resection was incomplete, and if there is a distant metastasis, and if the postoperative serum thyroglobulin is suggestive of like very high, suggesting a distant metastasis, and if there is a lymph node like with a large lymph node metastasis, and a follicular thyroid cancer with extensive vascular invasion, these patients should be regarded as a high risk. And what is different is the next management for these patients are different according to their risk stratification. So the first, the therapy for all the patients after the surgery should be done is the thyroid hormone suppression. And because the thyroid hormone can actually reactivate or have a give a signal for the tumor cells to proliferate. So currently the standard therapy after the surgery is the thyroid hormone suppression. And the level of the TG level, the target TG level for the target TSH level for the suppression is different according to the risk. So for the low risk, it can be maintained higher but in the intermediate risk or high risk, it should be maintained for the lower. But why we differ the target level of the TSH is because it is to balance the toxicity of thyroid hormone suppression and the risk of the recurrence. And actually, it is known that prolonged usage of the thyroid hormone suppression can have a high risk of cardiovascular mortality. And this actually, the predictive factor was the very low level of TSH. So we should stratify the risk, and we should give a different target level of the TSH. And after, without the TSH suppression, the other therapeutic consideration is the radioiodine therapy, and which will be the most familiar thing for us. And the purpose of the radioiodine therapy is for the remnant ablation is to increase the sensitivity of the thyroid globulin follow-up and the thyroid scan. And for the adjuvant therapy, the purpose is to reduce the local recurrence and remove the microscopic metastasis. Okay. There is a next question, so I think everybody could. So male patient with 36-year-old had a total thyroidectomy because of FNA result of malignancy, and pathology was unifocal of 2.5 centimeter papillary thyroid cancer. And from the pathology, there was no invasion, and the lymph node had a 10 out of 1 microscopic metastasis was seen, and the patient had a BRAF mutation. So what might be the next treatment for this patient? Okay. So I think the answer seems to be diverse, but mostly people are planning for a radioactive iodine treatment with 30 microcurie, so 30 millicurie. And frankly speaking, before that, we can refer that this patient may be relevant to a low risk, because of the size and no invasion, and although lymph node metastasis is microscopic. But frankly speaking, we also don't have I will say there is no practical answer for what to do next for this patient. Actually, in the ATA guideline, radioiodine therapy is recommended for intermediate or high risk patients, and in the low risk patient, it is said it is not routinely recommended. And for the intermediate risk, it can be it should be considered in, and it is considered by the, so these are how the patients are like stratified and whether the post-surgical radioiodine therapy is indicated or not. So according to the ATA guideline, for the low-risk patient, normally like the in the low risk, it is not routinely recommended. But patient with low to intermediate risk with a like if there is some evidence of the lymph node metastasis, it can be considered. And however, it is still controversial about the low or intermediate risk, whether this radioiodine therapy should be done or not. Actually, there is no evidence that there is a gain using the radioiodine therapy in the low risk group. However, there is also no definite risk that this post-surgical radioiodine therapy is not beneficial. Actually, this controversial is partly due to the lack of randomized controlled trial for this thyroid cancer. And actually, designing a RCT for thyroid cancer is very hard because of their natural characteristics of slowly growing tumor. And also for the low risk group, the prognosis is very good, and there is a less event of recurrence. So to conclude, it is very hard to design a RCT study. And so still there is controversial. And so large population and long-term follow-up is actually recommended to define whether it is beneficial or not. And actually, currently in Seoul National University, we prefer to give radioiodine therapy in the intermediate and high risk group. And for the low risk group for patients, we are also considering the radioiodine therapies. And there are also some evidences that in the, like, as you can see from the large database, that from the National Cancer Database, you can see that if the patient with a low T1, which is have a small tumor, and if after the surgery, if the radioiodine therapy was done, the hazard ratio was reduced, is like 0.7, which means that it has a beneficial effect compared to the average mortality. And also, the SEER database, which is comprised of like age less than 45, male, white, which T2 and 0, and which is which may be a low risk, and in this group, if the radioiodine therapy is not done, the hazard ratio was 1.3, meaning that there is a risk if the radioiodine therapy was not done. So these large databases are giving some clue that low iodine therapy can be effective, although still there is a like controversial result. So it still needs a large group of study, like RCT study should be done to define whether it is beneficial in the low risk group. But still, we can, for currently the guidelines, I would like to review some guidelines, how they are recommending. And in the NCCN guideline, NCCN guideline, they say that radioiodine therapy is not typically recommended if all these criteria are met, like the classic papillary thyroid carcinoma, and the largest primary tumor should be less than 2 centimeters and intrathyroidal and unifocal, or like when multifocal, the foci should be, all foci should be less than 1 centimeter, and like no detectable anti-TG antibodies, and like postoperative unstimulated TG should be less than 1 nanogram per ml. So, and negative or from the postoperative ultrasound. And if these all criteria meet, that radioiodine therapy is not typically recommended. But there is also a gray zone, like it can be selectively recommended in these patients. But like and again, usually if any of these criteria is met, you should consider for the radioiodine therapy, but it can be considered according to whether the circumstance of like whether there is a small volume of the metastasis, or like other like clinical or pathology findings should be considered whether to select the radioiodine therapy in this group. And also, if there is a gross residual disease and extrathyroid extension, and if the tumor is like higher than longer than 4 centimeters, and if the postoperative TG is high, the radioiodine therapy should be done in these patients. So still, it is still controversial, and there are gray zones whether the radioiodine therapy should be done after the post-surgery in significantly for like low risk and intermediate risk of very low, also like low to intermediate risk patient. There are gray zones. So I think there should be I think all those centers, each centers may have their own criteria or protocols how to select the patient undergoing radioiodine therapy, and it should be considered with a discussion with endocrinologist. And still there should be a need of like large RCT to find out whether really this therapy is needed for the low risk or some intermediate risk group patient. And another concern is, so we have defined that this patient should go on for the radioiodine therapy. Then we should choose what kind of dose should be delivered to these patients. And from this prospective trials, it have been shown that, firstly, compared with the thyroid hormone withdrawal and the recommended on TSH, there seems to be no significant difference in the treatment efficacy. And nextly, for the ablation success, compared with the 30 millicurie, 100 millicurie, there is no difference. So from these data, it refers that 30 millicurie can be preferred for the purpose of ablation. And also from the meta-analysis, it is known that low-dose radioiodine activity is sufficient for the thyroid laminin ablation, and it also has less common adverse effect and shorter hospital stay, which can be effective. However, actually, there is a concern, especially in Korea, because the ablation success rate when using the 30 millicurie was actually near 69%, which is relatively low compared to the other previously reported data. And it might be due to because of like BRAF mutation or high iodine uptake intake in the Korean patient. So we are concerning whether what might be the better dose for the patient for the purpose of ablation. And also, there has been a report that when compared to the 100 millicurie, like if you give a low dose for the ablation, there has been more chance to do a higher dose in the second radioiodine therapy. But still, so like in the guidelines, there is a dose recommendation. So for the low or intermediate risk radioiodine dose can be delivered from 30 to 100 millicurie. And for the in order, if there is a suspected microscopic residual disease, you can give like more for proposed adjuvant therapy. And if there is a aggressive histology, more can be given. And in SNUH, we give we give as this kind of protocol. So actually this 30 to 100, and actually it is not only a ablation, but also like for the adjuvant. But the gray zone is staying in this 30 to 100 millicurie. So it is considered based on some discussion with our endocrinologists. And so patients who are subject to high dose treatment but require a certain level of dose adjustment due to age, kidney dysfunction, or low body weight or clinical reasons, we can adjust from like 30, 50, and also 100 millicuries. And again, so now we have chosen the patient should go for the radioiodine therapy, and we have chose the dose for the patient, and the patient should be prepared. And there are the proposed is to increase the uptake of the radioiodine, and we prepare like there can be two preparation of thyroid hormone withdrawal or using the recombinant TSH. And as previously seen, there is no difference in the treatment efficacy. However, usually the TSH, the thyroid hormone withdrawal is done for like if there is a gross residual disease or as a adjuvant treatment in the high-risk patient. And for the recombinant TSH, it is actually relevant to how our Korean insurance is covering. So currently, the insurance coverage for the recombinant TSH in Korea is for if the purpose is to removal of residual thyroid, so purpose of ablation, and it can be done once. And during follow-up, if we want to during the follow, we can do once to check the TG level. And also there are some exceptional cases in patients with reduced pituitary function. It can be insured covered case by case. So normally these two are the currently insurance covered for the recombinant TSH usage. And we usually, for the ablation, we usually give a recommended TSH to for increasing TSH for the patient. And for the patient preparation, the target level of TSH is normally reported as it should be more than 30. However, like for patient, like ideally, we think like more than 50 might be efficient for the efficient delivery of radioiodine. And the target of low iodine diet is less than 50. And for Korean, actually, they have like high iodine intake. Like the average iodine intake per day is near like 350 microgram for Korean. So our reasonable target is set up to 100 microgram per day. And the days of iodine restriction is recommended in the ATA guidelines for 1 or 2 weeks. Okay, next, so we have done the radioiodine therapy, and for the patient who have underwent the therapy, we do the radioiodine scan. And actually, this scan is recommended to further treatment planning. And like from the previous report, it has been found that 10%, like using this post radioiodine scan, 10% of patients were have an effect in the later management of their treatment plan. And moreover, the SPECT-CT has a more importance. And if you additionally do the SPECT-CT, you can have a like 6.4% more patients to change of risk stratification level, which will have a significant impact on the future management. Okay, I think we can have so I think not much is left, and I think we can have some discussion after a couple of slides. Okay, so after the like initial therapy for like post radioiodine therapy, we need to define the response. So there are 4 categories of response to the therapy, and it can be excellent response and biochemical incomplete response, which means a abnormal TG or rising TG antibody in the absence of localizable disease, and structural incomplete response, which is a persistent or newly identified local, regional, or distant metastasis. And there is, like lastly, indeterminate, which is close, maybe more close to the excellent response or in the middle of the biochemical incomplete response. So more definition is, it can be seen here. And what you need to understand is the definition is differed according to whether the patient had undergone radioiodine ablation or not. Because in these patients, like the TG level might be higher, so the threshold TG level is different to define the excellent response. And also, like if the patient have not done the total thyroidectomy, the criteria should be also different. And so, like it is known that most of the low-risk patients after this initial therapy have an excellent response. And like half or more than patients have an intermediate patient have an excellent response. And it is known that 14 to 16 patients have shown an excellent response. And why these are excellent responses that these patients have a very low recurrence rate after a 5 to 10 year follow-up. And for the indeterminate response, it can be defined as this, so you can refer to it. And it has been reported to have a recurrence rate of 13 to 20% in the lifelong follow-up. And for the biochemical incomplete response, so like if where the TGs are positive but no negative for the imaging. In here, the patient at the 5 to 10 year follow-up, patients have found out a structural lesion at 8 to 17%. And for the structural incomplete response, it showed, as you can expect, a highest mortality. And for the distant metastasis, the 15-year survival mortality was high to 57%. So as you can see, according to this response categorization, the risk of recurrence or the survival can be re-stratified. So what we need to do after the initial therapy is to evaluate the response. And according to that response, the risk should be re-stratified. And so what we do, so after this initial therapy, we have to evaluate the response and re-stratify. And why we re-stratify is the follow-up schedule or the management after the therapy, it can be different according to the response. So like for a serum TG, if the patient had an excellent response, you can do a 12 to 24 month period follow of the serum TG. So it can, serum TG, thyroid sono, or diagnostic scan can be different according to the response. And again, FDG PET also can be done for the follow-up of the thyroid cancer patient. And when it is indicated is when there is a high TG with negative iodine scan, or if we are using for a staging for poorly differentiated or hostile cell thyroid cancer, or if there is a, so this is just the proposal of the follow-up. However, these are not, but you can also use for the distant, for the prognostic evaluation. And also in some case for the treatment response of systemic therapy, we can use F18 FDG PET. However, for the follow-up, the usual indication for us is that when there is a high TG with negative iodine scan. And so which I have upper mentioned that the treatment management plan differs according to the response. So for the excellent response or indeterminate response, for the thyroid hormone suppression target can be different compared with biochemical incomplete response or structural incomplete response. Okay, okay, now, 53-year-old male patient had a PTC with lymph node metastasis. And the patient had underwent total thyroidectomy with a central neck dissection and had 2 times of radioiodine therapy. And from the last radioiodine therapy, the scan was negative and TG was maybe negative, but there was a TG hype in the TG antibody. However, you can see there was a suspicious nodule in the neck zonal, and the aspiration was shown that TG level was high, more than 2,000. So which might be suggestive of the metastatic lymph node. So what might be the next treatment applicable to this patient? Okay. Okay, I think we can now end up. And then, so I think quite diverse, but mostly people first was to do the neck dissection operation for neck dissection. And next abundant answer was to perform radioiodine therapy more than 100 millicurie. Yeah, it can be controversial, but still, for the local recurrence, the guidelines recommend that the first option is to do the neck dissection. And like for like alternative option can be percutaneous ethanol injection or RFA or external. So local therapy is the first option for the treatment. And radioiodine treatment can be also done after the operation, the local treatment that recurred the lesion. But however, it can be also considered if the lesion is inoperable and when we treat, like usually the recommended dose is near 100 to 150 millicurie to treat lymph nodes and in the neck and mediastinum. And for the metastatic, if there is in the follow-up, if there is a metastatic disease, normally for the pulmonary metastasis, it is recommended to give 150 to 200 millicurie. And the importance is to give repeated dose for as much as possible, because these micrometastasis has been reported can be cured like using this repeated high dose therapy. So if there is no like radiation toxicity, it can be effective if it is if the high dose is repeatedly given. However, for the macrometastasis, still there is an effect, but the complete response, it is reported that complete response is hard to achieve in a macrometastasis cancers. And for the skeletal or other distant metastatic diseases, it is preferred to give the high dose of like 200 millicurie, but also it is more rarely hard to achieve a complete response in these patient groups. Okay, I think this might be the last questions. So the patient was 64-year-old female patient with PTC and had a total thyroidectomy and had 3 times radioiodine therapy with 100 millicurie. And in the last iodine scan, it was negative and the TG level was 7.3. And after the third radioiodine therapy, the on TG level was checked per 6 months for 2 years and there was a elevation when we can check a elevation of a TG level up to 5.7. And so we went on to see whether there is a structural lesion, but however, there was no evidence in both the neck sonography and FDG PET. So there is a positive TG, however, no evidence of disease. And so what might be the next treatment for this kind of patient? Okay, we can now stop and I will. So the most abundant answer was to observe further observation, and the next was to do a empirical radioiodine therapy. Okay, so let's see. So normally, like serum, if there is a serum TG positive and scan negative case, we can have a two choice as been answered from the previous question, active follow-up or empirical radioiodine therapy. And how to choose is from the recommendation, it is known that like if the non-stimulate TG level is less than 5 or stimulate TG is less than 10, it can be, we can do a active follow-up for this kind of patient. However, if the non-stimulate on TG level is more than 5 or stimulate TG level is higher than 10, like, and if there is a rapid incline of TG level, like 100 to 200 millicurie empirical dosing might be helpful. And also there is like some report actually from our institute, Professor Jungi Chong showed that like this hepatic visualization on the iodine scan can be a marker for such a non-structural but metastasis without like structural lesions, and it can be hidden metastasis. It is a marker of a hidden metastasis. So in this kind of hidden like maybe serum TG but scan negative cases, you can select the next treatment choice according to the level, TG level, or the time, and also considering the incline of the TG level. So maybe in this case, as the TG level was higher than 5, we can give a empirical radioiodine therapy for this patient. So currently, this is informal, but this is what we in Seoul National University and generally how to treat after the first ablation. Like in if the low TG and no or minimal remnant, we end up the treatment. Or if there is low TG but remnant, we can do a follow-up with TG and iodine 1, 2, 3. And if negative, end up. But if positive, we can do a low dose treatment with 30 millicurie. And if like high TG and remnant, we can do a also 30 millicurie. But if the TG level is high, and we can do with a higher dose of like 100 and 150 millicurie. And for the distant metastasis, we treat patient using a more than higher dose, more than 150 millicuries. And also these are some NCCN guideline recommended how to deal with a recurrent diseases. So you might also can refer to how to and when to consider radioiodine therapy in the recurrent diseases. And lastly, I'd like to talk about the radioiodine refractory diseases. And the definition of the radioiodine refractory is that when like there can be 4 different situations and when tumors do not ever concentrate the radioiodine, or loss of ability of accumulating radioiodine, or radioiodine uptake in some lesions while not in others, or disease progression in spite of the radioiodine uptake. Then in these cases, we can define the patient as a radioiodine refractory disease. So there are some known mechanisms of how these dedifferentiation comes due to a mutations or epigenetic changes. However, so there are also many attempts and studies to redifferentiate these cells to have restore the radioiodine uptake ability. So there are some treatments, and these are some summary of how these treatments act and at what kind of molecular pathways they are acting. So like what we largely known is the retinoic acid and like PPAR gamma agonist or histone deacetylase inhibitors can be used, or TKIs recently has been studied for the usage, like dabrafenib or selumetinib has been shown efficacy for restoring the radioiodine uptake in the patients. However, still, like for the retinoic acid, and we have historically seen a efficacy and actually uptake, but the clinical evidence is still lacking. But we in Korea use, in some case, retinoic acid for some different, like such a radioiodine refractory patients. And so such a studies like using the selumetinib has been reported. And as you can see, there was a restoration, reuptake of the radioiodine after the therapy. And using it, you can have more like patient with the response, although all the patients were refractory to the radioiodine. And finally, like without those redifferentiation, another, like if there is still a refractory to the thyroid radioiodine therapy, our next choice for those patients should be a systemic therapy. And right now, the preferred regimen preferred regimen for those refractory thyroid cancer patients are lenvatinib, and in some cases, sorafenib can be considered, and cabozantinib can be also considered if there is a progression after lenvatinib or sorafenib. And according to the mutation status, although not like approved, authority approved, but you can give like, according to the mutation status, you can select a drug targeting. And like currently, some clinical trials have shown that pembrolizumab has a efficacy if there is a high mutation burden in the tumors. So these can be considered if there is a still refractory disease after the radioiodine therapy. Okay, so I think this is end of my lecture today. And would there be any questions or comments? I think, yeah, hello.
Me? Yes. I am Stefanus from Tersutomo General Hospital in Surabaya. I want to ask you about undetectable thyroglobulin antibody. Some laboratory results show about like 1 to 100 is negative, and above 100 is positive. So how about undetectable? What the meaning of undetectable in this case? We can say 1 until 100 is undetectable, or just only for zero thyroglobulin antibodies that we can say undetectable thyroglobulin antibody. Thank you.
Oh, actually, yeah. I actually forgot the threshold or that for the thyroglobulin antibody baby. And would there be some one who could comment for the questions? sorry, I
Thank you.
will again. I think next time I will figure out in our institute about how to interpret, and then I will inform you next week.
Thank you very much.
Okay.
And the second question about your experience in redifferentiation. How effective the redifferentiation of the natriureum guidance importer?
Oh, actually, for me direct from the data from our institute, we have using the retinoic acids, we can induce some responses in 20 to 25% of patients for the radioiodine refractory patients. So I think, but not like about 25% maybe had some beneficial using the retinoic acid right now. So we consider, but in other agents that I have introduced, like the thyroid kinase inhibitors are actually currently not used in our institute right now. So we don't have that much experience about whether they have real beneficial for restoring the uptake of the radioiodine uptake. Actually, I haven't seen a real data from our institute. So I think I have limited experience about that, but we only are doing the retinoic acid for these patients.
Thank you very much.
Okay, thank you for the questions. And I think I think we have also next week expert from Indonesia and Vietnam will also share us their their expertise status. So I think it may be very helpful, and we can also have a interactive discussion regarding the status, and because I think there are still very much of gray zones of the indication or the dose of the radioiodine therapy. So I think there seems to be much to be researched and also discussed among the nuclear medicine physicians. Okay, I think now we can end up today's session, and then we can meet next week.
Yeah, Dr. Su.
Yes.
I have one question. Thank you for your nice lecture and informative lecture. I have one question. I think the journal from Korea several years ago stating that higher dose of iodine induce leukemia. I think years ago. So after that journal, do you prefer to lower the dose you give for the patients?
So yes, there was a report regarding the hematologic malignancy can be like secondary hematologic malignancy can be induced by the high dose radioiodine therapy more than like 200 millicurie. I think still that some controversial issues regarding the real risk of the high dose radioiodine therapy. And for us, we actually with the recently we have reduced actually the dose for the therapy, previously whether people might have like 100 and more millicurie, we have reduced like we are giving like in somewhat like 50 millicurie for patient, and we actually I like to say we have reduced some in some points, but there is always like we are always concerning what might be the appropriate dose. So I think it might not be an adequate answer, but yeah, I think we have compared with the previous study, our practice, we have reduced some doses from.
Okay, thank you, Professor.
Okay, I think then we can have more discussion next week, and see you next week, and thank you very much.